also our teachers. So, and it's the last session on this day. It was very nice, all the session before. I enjoy all of them, and a lot of attendees, also participants. Thanks for all participants, they staying with us till this time. And I will start with Dr. Majdi about his first presentation. Dr. Majdi Musa, he will give a case, and it will be 2 minutes only, or 1.5 minutes, then we'll discuss. Dr. Majdi, go ahead.
2 minutes. Thank you, Dr. Mohammed. I will have 25 minutes and then we will discuss. Thank you so much.
I cannot hear you, but there is something, okay.
Yes, in my ear, not in your ears. Anyhow, I'm sharing my screen. And here's the presentation saying thank you. And I have a couple of cases in 10 minutes, as I promised you. I will stop at the end of the case and we'll discuss for 30 seconds if anybody has any opinion, and then I will continue. How about that? This is a female patient. She is 19 years old and she had bilateral diminution of vision 6 months ago. And best corrected visual acuity 660, which is 2200 in both eyes. She's emmetropic. Medical treatment, she is on steroidal and non-steroidal eye drops plus cycloplegic since a couple of months. Anterior segment was unremarkable. There is no uveitis, no cells, no flare. And posterior segment, there is uveitis, as we can see here in fluorescein angiography. There is uveitis, vitritis, and we can see the hot disc and some inflammation of the large retinal veins as a kind of vasculitis, mild vasculitis, and we will see the nasal retina, superior retina. There's late staining of the large retinal veins, and this is her OCT. There is relative foveal thinning, thin epiretinal membrane, which is common with the uveitis. And this is the left eye, almost the same, with a thin epiretinal membrane, minimal edema in the center of the macula, and still again some staining of the large retinal veins and hot disc. So the main feature here is uveitis, vasculitis, and vitritis. There's not much edema in the macular area. Most of the blurring of vision is due to vitreous floaters and membranes. And I looked at the periphery. She had a kind of intermediate uveitis. And this is also the periphery of the left eye. You can see faint lean staining of the large retinal veins. And this is my diagnosis, intermediate uveitis with vasculitis. The history is negative. She had systemic workup. And can any of the panelists ask me for any other investigation before I proceed to treat this patient? Because it could be idiopathic bilateral intermediate uveitis. Can any other investigation would help? I would do a systemic workup. But in these cases, would you think of any other thing quickly?
Dr. Majdi, I can see that you have done all the non-infectious uveitis workup. How about the infectious or any masquerade like oncology workup?
Great. But she's a 19 years old. She had no systemic disease. But what do you suggest for infectious ones, like TB, like sarcoidosis? That would I agree on. Okay.
Any history of aphthous ulcers, doctor?
Any history of?
Aphthous ulcers. Aphthous ulcers.
No.
Mouth ulcer.
No, she didn't.
Is she mainly arthritis or phlebitis or both?
She is phlebitis, mainly phlebitis.
Professor Musa, did you consider an MRI scan of the brain?
Why?
Just to look for the possibility of multiple sclerosis.
Who's asking?
Fahad Cure from the United Kingdom.
Okay.
Yeah, so like an MRI just to exclude the small possibility of demyelination as a
Here is the MRI.
uveitis.
Here's the MRI.
Ah.
So you got the clue. She had
Demyelination, yeah.
She had MS, and I asked her about the joint. She said, yes, I have some joint problems long time ago, like elbow, like face, but nothing to be mentioned. I mean, but the MRI was the clue here because I did all the infectious and non-infectious disease. And she went, that was 7 years ago. She went on interferon therapy and she is getting better. She had cataract because of the local steroids she had for a couple of months, but she improved to 618 and 618. And the vision improved a little bit. She had posterior subcapsular cataract. Most of the vitritis is gone, as you see here, and she's improving on the systemic medication. So this is a quick message between the association of multiple sclerosis and uveitis. Look at this. there is prevalence of uveitis among patients with MS, which is high, and prevalence of, I'm sorry for that, and prevalence of MS among patients with uveitis. Both of them are high. So you should anticipate MS in the differential diagnosis in young patients with no positive data in the investigation. This is my main message for you. And this is a brief report about intermediate uveitis in childhood, predicting the diagnosis of multiple sclerosis in a 13 years old. After 13 years, she developed uveitis. So my take-home message in the first case is intermediate uveitis with vasculitis is common in MS, more common among females. Age starts from 20 to 50, and most common form of uveitis of MS, though the optic neuritis is the most common ocular sign. So look at optic neuritis in most of these cases, because sometimes it is the cause of diminution of vision, and it's characterized by vitreous condensation, as we have seen. You have to look at the periphery to look at the snowball structures in the pars plana, in addition to vasculitis. So this is the main picture, which happens in young age. Shall I move to the next case?
Yes, please. Yes.
This is a very simple case of CS. We yesterday discussed a lot of cases of CS. A male patient, 24 years old, he had history when he came to me of chronic CSC. He was medically treated by spironolactone, and he got much improvement. And this is his picture scanned from his file. So he got this picture. He said, this is my first presentation, and this is after I got treated. And he was much better. Then he relapsed, and he came to me when he was relapsing. So he asked me, should I start the treatment again? And this is his pre and post treatment when he was fine, and he was 612 in one eye, 6'9" in the other eye. So this is the case. Where should I go from there? Should I start again spironolactone, because he was already improving on that? Or should I start other modality of treatment? Or should I leave it to the natural course? Or what should I do? Quickly.
Dr. Majdi, FFA is done this time after the relapse?
He came to me without FFA. He told me I need to be treated, and I asked him to do OCT again. But
OCTA, Dr. Majdi.
Yes.
OCTA.
OCTA, and you need fluorescein. What else?
Dr. Majdi, if you look at the OCT, you can see the elevation of the choroid there. And so this would indicate that there's something behind, you know. So you probably look out for VKH or posterior scleritis.
That's a very good thought. The elevation here is suspicious, but nobody looked at it. But it could be pachychoroid. But pachychoroid does not elevate the retinal pigment epithelium. So should I ask him? And here is his.
Dr. Muhammad Hashki, can you please? Okay.
This is his new OCT. He brought me this, and he told me, this is my new OCT. Should I repeat the OCT again?
So he's got something under the choroid. You can see even large.
Yeah, it is on the right side.
Yes. Yeah. This is, and I did scan the report, because the report saying serous retinopathy with thick choroid, but nobody commented on this. Look at this. There is something down there. Yes. I did fluorescein and OCT again, because when the man presented to me, he was 660, and this is his picture. I did sweat source OCT. Look at this. There is a CSC, but there is huge mass down there. And my first question to the guy was, did you do any operations before? He's 24. He said, yes, I had cancer colon 4 years ago. Cancer colon 4 years ago. And this is the picture. Look at the massive metastasis in there. So this is very unusual to treat a patient without baseline fluorescein, without looking greatly at the fundus, because in the central area, if you examine on a constricted pupil, you will see the serous elevation, but you will never be able to delineate this. And this is his fluorescein angiography. Massive metastasis in this eye. So again, shouldn't treat. This is the one I scanned, and it sounds there is a mass lesion down there. It's a small one, causing this serous detachment, but this is when I photographed him. If anybody looked at this during examination of different line scan, you should trigger that there is something under the retina causing the CSC. So CSC is not always benign. It is not always benign. You have to examine the periphery. You have to do fluorescein angiography at baseline. You should not miss a mass lesion like this. So
how frequent, Dr. Majdi, about this one? How frequent we can see such cases? I mean,
it's the metastasis always come to the center, but when the metastasis come in the paramacular area and it's reflected by fluid only in the macular area, it's very easy to miss. But dilated fundus examination, proper one, needed to be any patient who is suffering from diminution of vision with fluid in the macula, you have to examine the periphery.
I mean, here the clue, if the patient doesn't have, I mean, a colon cancer, and we didn't know about that one, so it's very easy to miss more.
It's a mess. I mean, one of the panelists asked me, what is elevating the retina? Something is elevating the retina. And because we don't do EDI or we don't do swept source, sometimes we miss this lesion. So my advice is, with CSC, do a scan, examine the choroid very carefully. Thick choroid is completely different from mass in the choroid.
Do we need to do here CT scan for that? I mean, for special for that?
By the way, he left me and he went to the oncologist and he never showed up. He never showed up. This is the bad story. Probably had metastasis in the brain or in the bone. Probably.
I think, Dr. Majdi, the other thing would be on fundus exam. If you do a detailed fundus exam, probably would pick up this elevation as well.
Again, if you are not capable of doing fundus exam, don't send the patient of CSC to OCT only. Do fluorescein and OCT because you might find differently. It could be hemangioma. It could be tumor mass. It could be nevus. But again, you need to have a clue for any case with even simple CSC. And the trick is he improved on spironolactone. He was improving.
It's a very important point because a lot of people, and I notice a lot of ophthalmologists just rely on OCT a lot these days, and they just miss a lot of, not because they don't use the fluorescein angiography. And they actually are scared of sending patients to do a fluorescein angiography.
Telling you the truth, even OCT can detect this, but careful OCT. If you do multiple line scans or you scan the macula, you will detect this. But don't look at the line scan and put in your mind, this is the diagnosis. You will write a complete report on the diagnosis, though it is wrong. So OCT can get the clue, but please use OCT properly. This is my message. Thank you so much.
Thank you very much, Dr. Majdi, for this really interesting cases. And as usual, we will go for the next presenter.
Okay.
I'm searching for the...
It's me.
Who's that?
He took the screen. He's already took the screen.
Yeah.
Okay.
Dr.
You know yourself. Okay, good.
Yeah, I know myself.
Bahrani. He's a Bahrani.
Yes.
No, we changed, Dr. Hassan. We changed. You are the last. Okay, but you can go ahead. No
problem. Oh, really?
Don't listen to him.
Okay.
Don't.
Okay. All right. So let's go ahead and get started. Thank you, Dr. Amari, for this wonderful conference. This case about a mother and a son. So this patient is 26-year-old, presented with decreased visual acuity in his right eye for the past 1 month. His visual acuity is hand motion, left eye 20/40, otherwise unremarkable. His posterior segment examination shows exudative exudate and retinal edema in the right eye and the left eye. There's evidence of superior area of exudation, superior temporally and nasally, and the right eye. Also in the left eye shows there's evidence of exudation above the superior arcade. So these are the lesions. There are large lesions, medium-sized lesion, and small lesions. Looks like a blood mass with fibrotic stalk over the large one, when some peripheral exudation around it. And there's also some large feeder vessel. It's a little bit hazy, but it's pretty obvious. So our differential, we need to think about Coates disease, Leber's miliary aneurysm, which is the adult Coates, retinal capillary hemangioma, retinal cavernous hemangioma, and the rest is pretty much low on the differential, but still you probably need to be thinking about it. So how do we manage this case? You need to get an OCT, a fluorescein angiography. As I'm thinking about retinal capillary hemangioma, if you have availability of testing, that's important to do. Also, you have to keep that retinal capillary hemangioma in mind. You probably need to send for norepinephrine, epinephrine, urine blood levels, and you need to get a CT MRI with contrast to delineate any other lesions. And also examination of the parents is important. So I sent him for CT abdomen, and surely enough, there was both kidney lesions, probably not delineated not discrete in the right kidney, but in the left, it's pretty obvious. And and this is probably a better view of those lesions in both kidneys. He was referred to a surgeon who resected those lesions. So this is, association with Van Hoppen-Lindau. You have to think of other lesions such as CNS hemangioblastoma, renal cell carcinoma, and pheochromocytoma, because this is a life-threatening disease. And the VHL is autosomal dominant, so you have to be able to see the parents and request the examination of the parents as well. Management for this includes, in the past, it was pretty much just laser retinopexy and probably cryotherapy. But now, since we're, for the past 20 years, been using anti-VEGF, it's actually very important to use anti-VEGF in these cases because it reduces risk of exudation. And for laser retinopexy, you probably want to be doing the barricade laser around it, such as what Gaz suggested, before actually treating the lesion. If a lesion is more than 4.5 millimeter, then you probably want to use cryotherapy. And there's been a report of surgery ligation of those feeding vessels. This is fresh post-laser retinopexy. You see, I have actually done the barricade laser a month prior to treating the actual lesion, and it seemed that it took pretty well. He underwent multiple anti-VEGF treatment with the laser retinopexy. His vision improved to 2400, and his left eye also improved. And now his 8 months post-laser retinopexy, you see that the fibrotic lesion, especially the one in the left, which is the bigger one, but the other ones, you notice still activity. So I actually lasered it again. So where did the mom go from this case? So the mom shows up a year later, and she complains of decreased visual acuity in the right eye. And her past ocular history, laser retinopexy in that same eye, the right eye, but she has no clue why. And the left eye is phthisis bulbi because quote unquote retinal detachment that failed treatment. And I did her examination, showed 20/70 vitreous hemorrhage, hazy view, subhyaloid hemorrhage with a PVD. And on B-scan, I thought there was a retinal tear. So in this case, in a monocular status, you probably need to operate. And so I'm not going to go over because we don't have time. I did the initial treatment where I found that she has also, the reason for the vitreous hemorrhage was the retinal capillary hemangioma at 12 o'clock. And I sent her for imaging and showed these little bitty lesions inferior in the inferior pole of the kidney. That's pretty obvious there. So it was kind of, but it seems that the mom didn't have, how would you say, the presentation like her son. It actually didn't look that the disease has affected her like her son. So her visual acuity 3-month post-op was 20/20 after the initial surgery. She had flat retina with epiretinal membrane, and then she came with a macular hole 15-month post-op. And then again, I just wanted to show this video, not to show the entire video, but you can see the retinal capillary hemangioma superior on your view right there. And it was still active. I had to treat it again, along with doing the peeling and so forth. But thank God the macular hole was closed and she's stable at 20/30 now. So finally, this disease is not uncommon in retina specialty, and careful evaluation of the retinal lesion, type of lesion will lead to the diagnosis. This is a life-threatening disease, must be managed accordingly. Full workup for any association with von Hippel-Lindau syndrome, along with examination of the parents. The fact that I told her, why you didn't come for examination for the mom, she said we were just so busy and shocked with the news of what what her son had. So she never showed up until her vision dropped. Thank you.
Thank you very much, Hassan. Any question for Dr. Hassan about this? Dr. Majdi, if you want to comment.
Yes, not comment, but a question for Hassan. You did laser treatment, right?
Yes.
That's a good idea, but I would, injection, as you said, it's life-saving in this because you need to prevent the heart exudus from affecting the macula more. But would you agree with me or disagree about using cryopexy? Because it's a peripheral lesion, you can attack it with cryo easier than laser, because as you said, laser need multiple sessions because you need to surround and then you need to hit and you need the lesion itself. And sometimes it's very dangerous to attack the lesion before surrounding tissue. So wouldn't you agree if cryopexy would be solving the problem after multiple injections? Because it's a peripheral lesion, you can reach it easily and you can do extensive cryo for the lesion itself. How about that?
Well, my thing was that I was gonna treat it with injections and laser retinopexy, and if that doesn't work, then I'll probably go for cryotherapy. So that was especially for that large lesion over there. Because see, this was a fresh out of laser retinopexy, and you can actually see how it took laser pretty well. So the barricade laser, you see that surrounding the lesion, but the laser took very well. So that's why I was confident that I may be able to not take him to cryotherapy. And your cryotherapy, after cryo, you have the conjunctival edema. So I wanted to give it a try.
Any question, Dr. Muhammad?
Dr. Hassan, I would like to ask you, Dr. Ayman, go ahead.
Yes, Doctor.
Dr. Hassan, this is a very nicely managed case. Thank you very much. But I would just to stress one point that Majdi already mentioned. Cryo in these cases, in some cases, has the advantage of also you can at the same time aspirate some of the subretinal fluid if you cannot access the lesion and do the cryo at the same time. But obviously, the patient or the retina has taken the laser very well, and the results are really marvelous.
Dr. Muhammad Hashki,
yes, I would like us, Dr. Hassan. Why didn't once it is an extensive lesion and involving many areas in the retina, why do you think to think of surgery? Vitrectomy, and you do endo laser.
Well, I mean, if the view is good, I mean, why would I, expose him to the risk of surgery? I mean,
by the end, I mean, you go for the surgery, yeah.
But he didn't need surgery. He was
the mother did surgery, not the patient.
Yeah, I mean the mother, yeah.
Yes, but this is not the mother. This is the boy.
The boy.
Exactly. Yeah.
Can I make a final comment, Dr. Muhammad?
Go ahead, please. Yeah.
For the audience, it's a very good case. It's a very illustrative case. But we have the three options. We have the cryo, which is successful in here. The laser. We had the cryo, and sometimes vitrectomy is indicated, as Dr. Hassan knows, if some of these patients come with vitreous hemorrhage sometimes. It's inevitable to do cryo. But if you have a clear media, both of them can work, laser and cryo. But if you don't have a good access to the laser, you cannot reach the periphery. If the lesion is too high, cryo can do the job. But both of them are right. But again, the main message here, use anti-VEGF once, twice, and 3 times if you need it to stop the leakage into the macula, because this is an exaggerated macular response with exudative detachment. We are looking for vision. So stop the leak into the macula, the exudation into the macula, and then treat the lesion. And this will be, even with anatomical success, sometimes the patient will not improve. So all of them.
Can I add a point?
Sure.
Yes.
Yeah, please. Yeah, Dr. Prasan, go ahead.
So Dr. Hassan, very well managed case actually. Yes. But I have just a comment. You said examination of the parents. I think we should also need to stress that the examination of the siblings is important because it's an autosomal dominant condition.
That's a very important point.
And sometimes the siblings might present with just capillary hemangioma without any systemic association, in which case they have to be monitored because they might develop pheochromocytoma or retinal cell carcinoma, as you mentioned, in future.
Very good point.
Future, yeah. Thank you.
Thank you, Dr. Prasan. Just last question before we move to next presentation by Dr. Ayman. How can we anticipate, I mean, if we want to tell our participant, when do we should think about doing all this investigation and send patient for MRI and think of kidney disease, Hassan?
Well, I mean, as soon as you see this lesion, I mean, you really have to immediately think of other systemic etiologies, and therefore, because I mean, you're talking about life-saving thing. I mean, this is when an ophthalmologist can save a life. And I
But
think
Hassan, I mean, my question is particularly why you are sending for abdominal. Maybe someone he will say, I will do a CT scan for brain. Why you select to do for
you have to
abdominal?
do all of it because of the pheochromocytoma and because of the renal cell carcinoma. And so he had actually both a brain and abdominal CT without
Dr. Mohammed, can I just
Yes.
add? Actually,
But
this
scan
case is
is very
classically.
important, these cases.
Yeah.
The retinal capillary hemangioma is a clinical diagnosis. Once you see it, the first thing which you should look out for is a von Lippel-Lindau association.
This is what I want to hear from Dr. Hassan. That's
Yes.
why my questions.
Yeah,
Okay.
yeah. So the moment you see it, you have to make sure the parents are screened, siblings, and all of them undergo investigations because, as mentioned, it's an autosomal dominant condition. So the incidence of inheritance is very high.
Okay, thank you very much for all of you. Can you stop share, Dr. Hassan? Thanks a lot, Hassan. As usual, you are present interesting case. We'd like also now to introduce dear Dr. Ayman Midana to present his case. Dr. Ayman.
Thank you, Muhammad, for inviting me. This is
it's our pleasure and honor, Dr. Ayman.
At all, and it's really. Let me just see now. Yep. In fact, I'll have an unusual approach in my cases tonight. I'll be talking about surgery for macular buccal, why some patients benefit and some others do not. We know that in macular buccal surgery, most of our patients, they end up with good visual prognosis, but some of our patients, in fact, do not improve. And in the few patients, the vision might even worsen. I'm going to discuss a few cases with you and considering the factors that will affect the visual outcome post-operatively. The first one is, and I think Majdi will be very much interested in this, is the integrity of retinal layers, especially the outer retinal layers and the photoreceptors using the OCT. This is
Dr. Ayman, you are mute. Dr. Ayman, you are mute. Can you unmute yourself, please?
Yes.
Yes, I now. Yeah.
Yeah. This is a 70-year-old male patient with a visual acuity of 0.6. He's a lawyer. The left eye is 6.6. He was bothered. He has a little bit of metamorphopsia. He insisted in doing surgery. We did the surgery. This was in 2011. And this is in 2014. He's back to 6.6. But let me just confirm one thing. Look at the inner retinal layer in this picture. It's mainly an intact inner retina. This is why I think this patient has this excellent and nice morphological and functional outcome post-operatively. I know that we don't have this result in every case. Every one of us will wish to have this result, but unfortunately we don't have such results in all our cases. This is a 60-year-old lady, hypertensive, presented with blurred vision in her right eye. She has a stage 3 macular buccal, 0.6 vision. She presented in March 2019. She had an increasing metamorphopsia and vision of 0.4. At this stage, we decided, and she wanted to do the surgery. We did the surgery for her. We removed, it was a relatively, just not very thick, but a relatively thick membrane over the macula. I usually do triamcinolone assisted vitrectomy, but in this case, there was a complete PVD. I did not use it. I just removed the membrane. I don't remove the ILM in most of my cases. This is in April 2019. Look at the inner retina, the photoreceptors there, it's very intact. And in July 2019, her vision is 0.8. Very good result. But look at this case. This is an 87-year-old male patient, hypertensive, ischemic heart disease, 0.3 vision. Look at the inner retina. Look at the retinal layers. This is advanced stage 3. macular pucker. We did the surgery. This is the result after surgery. He has a good morphological result, but he has a disappointing functional result. He's hardly 0.4. I'm saying hardly. We pushed him to see 0.4. I think he was, his vision was almost the same. The patient was not happy. I was not happy. But look at the inner retinal layers. It's not as good as the other cases. So looking and evaluating these cases preoperatively with the OCT is very important. The duration of visual loss is also important in cases of macular pucker. This is a 61-year-old healthy patient discovered to have cellophane maculopathy. When I say cellophane, I mean stage 1 and stage 2 and early stage 3 of epiretinal membrane. When you go to stage 3, advanced 3, and stage 4, it's usually the macular pucker with a contraction. Now, she had the cellophane maculopathy with 6/6 vision. We did not do anything. We decided to observe. The patient has a tragic event of losing her daughter. She disappeared for quite some time. She came back 15 months later with this picture, stage 4, macular pucker with vision of 0.1. We did the surgery for the patient. I've done this is recently. Triamcinolone assisted vitrectomy. I keep some of my triamcinolone in such cases. I keep it in the eye and just to assist us to decrease the macular edema post-operatively. This is the result 5 days post-op. This is pre-op. This is 5 days post-op. The patient has improved to 0.3. This is very unusual in macular pucker. Patients do not improve immediately. In some cases, in fact, some of the patients might even worsen a little bit immediately after surgery. But I was astonished that the patient 5 days, the edema was much decreased and the vision improved. And I think this is because of the short duration of the disease. This is the surgery. This is the fundus before surgery. This is 5 days after surgery, and the patient improved to 0.3. The other factor is the presence of the chronic lesion and chronic leakage and hard exudates. This is another adverse factor affecting the visual outcome post-operatively. You can see in this case that there is chronic leakage with hard exudates. The membrane, in fact, is not that thick membrane, but the visual outcome was not satisfactory. The severe foveal dystopia. This is happening in cases of macular pucker with mature membrane when it contracts and drags the fovea away from its normal position, and this will affect the normal integrity of the retinal and foveal layers, and ultimately it will affect the visual outcome. I'm going to show you, I've done this surgery years ago. In fact, I think it's 2010. This patient is a young girl, and she has a very thick macular pucker, very thick epiretinal membrane. I have to carefully dissect the membrane. You can notice that there's a folding of the lower part of the macula, and there is dystopia of the fovea. The fovea was dragged. We have to cut the membrane, and even I removed the ILM just in order to retain the normal contour of the retina. Unfortunately, this patient did not improve much, has a very slight improvement after surgery. Macular edema, the development of macular edema or increased macular edema or persistent macular edema after surgery is an important cause of non-improvement or even worsening of vision after surgery. I'm going to show you this case. This is a 66-year-old male patient, healthy, presented with blurred vision, 0.3. This is before surgery. The morphology, the morphological results is very good, but the functional results is really bad because of this remaining macular edema. Just to conclude that the nuclear sclerosis, capsular pacification after vitrectomy might lead to decreased vision in due time. and definitely complication of surgery like the retinal tears, hemorrhages, and retinal detachment might worsen the visual outcome. However, it's worth noticing that in general, any improvement in sight will not be appreciated for several weeks and even up to a month or more after macular pucker surgery. The take-home message is that most patients with epiretinal membrane are stable and they don't need surgical intervention, but we should operate early. I insist we should operate early in cases which need surgery. OCT is the gold standard for pre-op and post-op evaluation of the outer retina and to predict prognosis. Using dyes usually facilitate the procedure. Visual acuity results may be hard to predict, especially in chronic cases, and ILM peeling yields greater anatomical success, but no improvement in the functional outcome. Thank you very much.
Thank you, Dr. Ayman, for this very interesting cases, not a case, about one topic, but very interesting in a different, I need anyone, Prasan, if you want, or Dr. Muhammad Naeem, if you have any question to Dr. Ayman.
Yeah, I'd like to make two comments, then I may ask Dr. Ayman a question. It's a very comprehensive presentation. I've seen there's several factors that affect the prognosis or the outcome of the pucker surgery: type of the pathology, chronicity, OCT findings, and presence or absence of the cystoid macular edema. These the factors that I've seen they affect the prognosis. The second thing, the question that I wanted to ask, and sometimes I incorporate this practice in my cases, is the use of the anti-VEGF either pre-op or post-op. Let me give you an example. Suppose you have a very chronic ERM and it's causing you cystoid macular edema. Now, if you go ahead directly with the surgery, there's always a risk of deroofing, causing lamellar or full thickness macular hole. So how about you give one injection or just injection to reduce that edema, and then you do the ILM peel, so it decreases the chances of comorbidities that can happen later on. And the second question, part same, the use of the anti-VEGF post-op. Sometimes, as you said, that it takes few weeks to months for the edema to reduce. And the vision acuity, it takes longer than that because first the anatomy integration comes back and the vision gets back later on. So in the post-op period, would you consider incorporating anti-VEGF if the edema is still persisting beyond 2 to 3rd month?
Thank you. This is a this is an excellent question, in fact. What I do myself is I don't inject in the first few weeks. I give the local steroid, topical steroid, and I give the non-steroidal anti-inflammatory drops. Usually in the first few weeks, this might resolve the problem. Now, if the edema persists, I usually I don't inject anti-VEGF, I inject steroid. I find that steroid is more beneficial as in these cases, the inflammation is playing a more role in the creation of macular edema rather than the VEGF itself.
Thank you, Dr. Ayman. Thank you, Dr. Muhammad. Prasan, if you have any question, or Dr. Hassan, Dr. Muhammad Hashki.
Yeah,
so I need to ask a surgeon.
Yeah, just
very fast and very fast answer.
Dr. Ayman, that girl you did surgery 10 years ago. I mean, I had these kind of cases, and I always thought that these are most likely a trauma case because of the strong adhesions. I find those. And then when I talk to them, you know, some of them admit and some of them just don't recall any previous trauma. But I think these cases are trauma related.
This was a very bizarre case, Dr. Hassan. In fact, I did everything. I investigated her regarding uveitis, history of uveitis, history of trauma. There was nothing at all in the past history. It was only this thick membrane over the macular area. And I was disappointed. I did a very good surgery for her. I removed all the membrane, I removed ILM, but the patient, unfortunately, did not improve. I lost this patient for follow-up.
Hassan, please,
ago, but,
Hassan, please show us so I can remember you.
It could be congenital because Dr. Ayman, it could be congenital in this case. Epiretinal membrane, sometimes we discovered around 9 to 10 years, and even if you did surgery, most of this patient, they said there is no improvement. Will be just you remove this epiretinal membrane,
Well, if it was congenital, as far as I remember, this patient vision was 0.2 before surgery. Congenital membranes, in fact, they have severe amblyopia, especially if they have this thick membrane over the macular area. The other thing is the patient was around 27, 28 years of age, and she reported that she had this in the last 1 or 2 or 3 years. She has this gradual loss of vision. So this what make me, curious to look for a cause in this patient, and unfortunately I did not find. I've done everything.
Why I tell you this? Because we have a series of 3 cases, children unilateral peritoneal membrane, diagnosis 3 years, and the vision just between 0.6, some of them 0.4, 0.8, and
yeah, it's a remnant usually of the hyaloid membrane.
And both, and all of them mostly unilateral.
Yeah, this
can I add a point?
You have to look at the hamartoma in this case. Hamartoma is very common.
Congenital. That's what I was going to say. The congenital hamartoma of the RPE.
RPE. This is very important.
Yes.
Cellophane with underlying hyperplasia of the RPE. I have a quick comment.
Give me 30 seconds. I just
want can we have Dr. Majdi? Yeah, please.
One comment. We have a lot of audience now. I see more than 300 audience. We shouldn't give them the idea, because I don't agree about injected anti-VEGF in epiretinal membrane. Because injecting anti-VEGF will strengthen the membrane. It's a cellular membrane. So you are strengthening the membrane. If this patient is injected and for any reason he did not commit to surgery, you will end up in a macular hole. This is number one. Intravitreal injection has no role except if this is a vascular element. We don't have any vascular element in here. We have a tractional element. So epiretinal membrane, it is not in the guidelines to inject this patient because you don't have any vascular element. Unless you have inflammatory and steroids, as Dr. Ayman said, it's the most important thing. Third thing, look at the OCT carefully. We have now very meticulous observation on OCT. Foveal herniation, we didn't mention anything about that. In this case, it was foveal herniation. And torn ILM, you will never have a regain of vision. Second thing, look at the outer retinal layers herniation, which is the detachment of the outer retinal layers. If you find a dome-shaped elevation of the central of the macula, this means that the traction not on the inner layers, on the outer layers. And this is the worst prognostic factors. But I'm against injecting for the audience. We have young ophthalmologists. We don't inject anti-VEGF in these cases because this is not in the usual manner. It's individualized. So if you are a surgeon, you insist, you can do it on your own, but it is not in the guidelines of treating epiretinal membrane, injecting anti-VEGF. This is my message.
Personally don't well.
Thank you. Can I ask
just one thing? I totally agree. There is no rule, as I said, for anti-VEGF in these cases. The only rule that you seldom, sometimes you don't need that much, is to inject some steroid if the macular edema persists post-operatively. That's it.
But there is a question.
Dr. Ayman, one question, Dr. Ayman. If you have the same patient who is diabetic, so he has diabetic macular edema, element of diabetic macular edema, and tractional macular edema, would you go for anti-VEGF before surgery?
This is a different. This is a
story.
Totally different
Yes,
subject.
and I know different story.
This is a totally different subject.
Yeah.
Now, in these cases, yes, I inject anti-VEGF preoperatively, and sometimes after removal.
When you do surgery,
I inject anti-VEGF even post at the end of my surgery. I inject another anti-VEGF. When
you do your surgery?
When I do surgery, when this tight membrane over the macula is affecting vision, when the vision of the patient is starting.
No, providing they have cystoid macular edema, diabetic macular edema, so vision is poor.
If the vision is poor, if they have a tight epiretinal membrane over the macula, this is the only solution. Muhammad, you have to go and remove this membrane for this patient.
Can we just I think I need Muhammad also, because he want to clarify point. I know what he was meaning, Dr. Muhammad, when he say he want to give anti-VEGF. So go ahead, Muhammad.
Yeah, my point is different. It's like when you have a case of a TRD and then you give them 5 days or 3 days before surgery and anti-VEGF, you're committed to the surgery. And your aim is to reduce intraocular hemorrhage and everything. Likewise, when you have, I'm talking by very specifically conditions, when you got huge, massive cystoid macular edemas. And before you commit yourself to the surgery, just before that, if you give 1 week or 2 weeks anti-VEGF, it makes your chances of developing macular lesions, macular hole, less likely. So if you are committed to the surgery, just like the cases of the TRDs, you have an aim. And it's not that you're treating it, it's just you're preparing the patient for the actual treatment, which is the surgery. Because I believe that you have to remove tangential and anterior posterior traction. I totally agree with that. And the second thing I want to mention, because I've seen one case where the patient presented with ERM and the resident could not figure out the diagnosis. And then we just did a complete fundus examination and there was a large horseshoe break without any RD. So one of the messages that I want to pass, whenever you have an ERM, don't forget to examine the periphery of the retina and look for retina breaks. That's it.
I agree. This is a very important point. In every vitrectomy, not just the macular surgery, in every vitrectomy, you have to examine the retinal periphery and look for retinal tears. This is a very valid point. But in cases of macular pucker, the causes of macular edema is not vascular. The cause of macular edema is mechanical. And when you are giving anti-VEGF, you are contracting the membrane more, even increasing the macular edema, not decreasing it before surgery. So be cautious before deciding to inject anti-VEGF in a macular pucker case before surgery. It's not like the diabetic case where vascular component is very important.
Thank you very much. We're already over the times. Thank you, Dr. Ayman. I know your cases, it will take a long time. If we take the whole day, it will not finish. So thank you very much for these interesting cases. Now we are going to show Dr. Fahad his presentation. Okay, Mr. Middle, okay, MEOM Teams, yeah, show. Okay. Okay, can you just play? Actually, Dr. Fahad, he sent his presentation in a link because he is driving, unfortunately. At the same time, he has something to do. And so he prepared for us this one. I hope that it will work fast. Okay.
I want just to say good evening, Dr. Fahad. It's really nice to see you again. It's long time no see.
Dr. Ayman, your voice is a little bit interrupted. I think the internet just, we hear you, but it was interrupted. Okay. So
I'm just saying, just saying hello for Dr. Fahad Kuhail.
Yeah.
He's a dear friend.
Okay. So is there any voice?
No, Fahad's voice is not there.
They need to replay it again, Muhammad, with my voice, if that's okay.
Okay. Is there a voice? We cannot hear a voice here.
Probably the video is very low voice, so he had to raise the voice.
Yeah, can you increase the voice, our team?
Good evening.
Yes, okay.
First,
now,
thank
go ahead.
Ambry for inviting me today and sharing and giving me the opportunity to share this interesting retina uveitis case. For those of you who don't know me, my name is Fahad Kuhail. I'm a consultant ophthalmologist here in Sheffield in the United Kingdom. I would like to present a case of a 52-year-old male tour guide who presented to our department with a 7-day history of redness, initially affecting the left eye, followed by the right eye, with blurred vision and headache. This was associated with non-specific illness that lasted about 3 days, with the predominant symptoms of fever, vomiting, and weight loss, which settled. When he first presented to our department, his vision was 6/6 in both eyes. His ocular signs were this granulomatous inflammation of both eyes associated with synecdoche, with bilateral vitritis, but on the right side there was also this area of retinitis in the superior fundus. He was initially seen by the general on-call team, who arranged for a series of bloods and chest x-ray, and because of the fever and systemic symptoms, was referred to infectious diseases, who started him on empirical intravenous antibiotics. He was commenced on topical steroids with sarcopenia to treat his ocular inflammation, An initial blood workup showed a high CRP of 89 with a raised white cell count of 14 with raised platelets of 513. Syphilis was found to be negative. All other examinations were negative. And because his ocular inflammation, particularly for his right eye, wasn't improving, the general on-call team decided to do a tap and inject because there was concern that this could be an endogenous endophthalmitis. And they injected him with ceftazidime, vancomycin, and amphotericin to cover both bacterial and possible fungal causes. His vision remains stable at 6966, but so far no positive results. All his blood cultures were negative, but his inflammatory markers were improving with empirical systemic antibiotics, and he was started on intravenous tazocine. And as I said to you earlier, he was given one course of intravitreal antibiotics to the right eye. A cardio echogram was requested, and a second opinion was requested for myself about a week after the onset of his symptoms. When I assessed him, I found his ocular inflammation wasn't particularly resolving. He still had a very persistent anterior uveitis despite hourly topical steroid, with quite a persistent vitritis in both eyes that hadn't improved with intravitreal antibiotics. I went through a battery of questions to see if there's any clues from any underlying systemic problem that might give me an idea to identify his etiology, any underlying etiology. And what I'd identified, that he revealed that he had an insect bite whilst in the Peak District that coincided with the onset of his systemic illness and ocular symptoms. Given that we still had negative results so far, and we were still awaiting results, and time was of the essence, following discussion with infectious diseases, we decided to empirically start him on doxycycline. As the results came pouring in, his echocardiogram was negative. His vitreous tap revealed no growth, with white cells only. HIV and other viral screens were negative. Also, PCR workup of his vitreous for HSV and VZV was negative. In addition, the vitreous was negative for any fungal markers or bacterial markers such as Borrelia with negative 18S and 16S. Quantiferin was negative, and we tested him for Lyme and rickettsial serology on 2 occasions, and both were negative. However, he had an excellent clinical improvement with oral doxycycline, with his vision remaining excellent at 6.9 on the right, 6.4 on the left, with marked resolution of his vitritis with more than a 2-step improvement. So that gave me the confidence that I was on the right clinical path, that it was likely that I was dealing with a tick-borne uveitis, even though serology was negative so far. And we couldn't identify any bacterial infection in the eye. This was his fundus photographs after the vitritis had settled down. And you can see there's an area of retinal hemorrhage where the vasculitis was in the past, with retinal hemorrhages, and there's his residual vitreous changes. His left eye is unremarkable. A fluorescein showed some superior capillary shutdown in that area of retinal hemorrhage. Obviously, even if you suspect an infectious cause, there's no harm in looking for non-infectious causes, and his autoimmune screen came back negative. Because of that area of capillary shutdown, I decided to apply some sector panretinal laser photocoagulation just to prevent any retinal neovascularization and potential threat or complication to sight from his retinal vasculitis. And I said to you earlier, the working diagnosis was of a Lyme or tick-borne uveitis. So let's talk a little bit about tick-borne uveitis. The one that you probably most likely have heard about is Lyme disease, which is caused by the spirochete bacteria known as Borrelia. Systemically, the pathognomic finding is of erythema migraines rash, which is present in 90% of confirmed cases. But other systemic manifestations include flu-like symptoms, lymphadenopathy, arthralgia, as well as cardiac and neurological involvement. As regards to the eye, they can get any type of ocular inflammation with anterior, intermediate, or posterior uveitis. And the posterior uveitis can range from a retinitis to a chorioretinitis to a neuroretinitis. So always have bear Lyme disease in mind, particularly if you have somebody who potentially could have been exposed to a tick bite. As for tick-borne diseases that are more likely to occur in the Middle East, don't forget about tick-borne rickettsia diseases, which are obviously caused by bacteria known as rickettsia, and often known as Mediterranean spotted fever. In these particular cases, you're going to get a rash that affects the skin, particularly the distal extremities, such as the wrist, ankles, and forearms. And obviously, it's in terms of its ocular manifestation, it's predominantly posterior, with vitritis, vasculitis, and optic disc edema, and occasionally even retinal artery occlusion. I think the moral of this particular story or this particular case is that always bear in mind that potential for a tick-borne uveitis, yes, it's rare, but it's treatable. And this gentleman was only on treatment for 28 days with no recurrence of his disease in the last 12 to 18 months of close monitoring. I hope you've enjoyed the case, and take care.
Okay. Thank you very much, Fahad. You are with us also, Fahad, in Now Live?
Yes, I am.
Okay.
I am.
Driving?
Yeah, he's still
No,
driving.
He's not driving.
I've parked the car somewhere.
Okay, at the same, he's in the car. Okay, so he's driving. Yeah,
I'm in the car.
He's driving.
Can I ask a question?
Yes. Okay, go ahead.
Thanks, Fahad, for the presentation. Please stay safe. Okay. Could you have sent PCR for Lyme since you have taken AC-TAP?
That's a very, very good point. So we did, from my memory, when we discussed the case with infectious diseases, that was an option to send PCR for Borrelia. But because we're already testing 16S and 18S, which are kind of parts of the genome which cover bacterial and fungal causes, as far as infectious diseases were concerned, if the 16S had come back positive, we would have just suspected it was Borrelia. Does that make sense? So when you only have a small amount of vitreous sample from a vitreous tap, you can only do so many PCR tests. So sometimes it's better just to do the virology tests, CMV, HSV, and VZV, and then do 16S and 18S to look for bacterial fungal causes, but then hope other tests will give you the answer, rather than. And to be honest with you, for this particular case, I wonder whether it was rickettsial rather than Borrelia, which is why I've labeled it as a tick-borne uveitis.
Okay. Any other question to Dr. Fahad? Yes, Dr. Ayman.
Yeah. Dr. Fahad, thank you very much. It's really a very interesting case. How to approach such a case? You know, the tick-borne disease affect every part of the eye, affect the conjunctiva, the sclera, the optic nerve, uveitis, etc. So how to expect that this might be a tick-borne disease, or it is just a diagnosis of exclusion?
That's a very good question. I think whenever you see any uveitis, and I know the panelists are all very experienced, but this is kind of the benefit of the audience. always assume, could this be infectious? Could this be non-infectious? Could this be a masquerade? And it's really important, particularly when you see a new uveitis patient, even if your pattern recognition means that you're able to recognize the diagnosis, it's really important that you take a very detailed systemic inquiry. So I always ask about travel history. I always ask about sexual history, particularly if there's any unprotected sex. I also ask about tick bites. I ask about TB. So this is, so every patient I see, I'm always asking and trying to identify, could there be an underlying tick-borne uveitis? This was the first case in 8 years of doing ophthalmology or uveitis in a tertiary referral center that I had a patient with a positive result. But in the end, it's important that you work with your infectious diseases. Don't try and make these diagnoses by yourself. If you're suspecting an infectious uveitis, and particularly a very exotic infectious cause, get ID's help, because they are excellent. They'll even suggest some additional tests that you probably haven't thought of. But also, the doxycycline, we were able to manage that patient together. But for me, I think the moral of the story was he was seen by the general on-call team. They started him on very reasonable treatment, topical steroids, cycloplegic. They considered endogenous endophthalmitis. Blood cultures were negative. He got an intravitreal antibiotic in his right eye, yet his clinical condition did not improve. And so then you have to stop and think, what else could this be? And then when he saw me a week later, and I'm seeing that very reasonable strategies weren't helping, I then basically started again and just went through every history in a tooth comb, And I recommend everybody, download a uveitis questionnaire from Stephen Foster's website in the United States. It has all the questions that you need to ask a uveitis patient. And then if there is something in that systemic inquiry, get one of your physician colleagues to help, and that's how you then get the diagnosis. So, a lot of your time as you as the ophthalmologist is to get the ideas and get a feel for what this could be, but then get your physicians to help you.
Thank you very much. Thank you, Fahad. Is there any question from Dr. Brasan or Mohammed?
I have
last question. Yeah, very fast, direct, please.
Yeah. My question is regarding the management. Such cases, I know they respond very well to the systemic treatment, whether oral doxycycline or IV trifloxazone. How about the use of the systemic steroids? Would you incorporate, and then when would you incorporate, if you incorporate it in your treatment?
That's an excellent question. So as you can see in this case, he had a very bad vitritis and quite a good going retinitis. So at every time I was thinking, should I consider, systemic steroid? But because it was still an unknown diagnosis, he had a high temperature. We haven't excluded an infectious cause. You could see he had raised white cells. I myself was a bit apprehensive about giving him systemic steroid. So the idea was, let's try him on the doxycycline. I saw him the following week. I was giving him phone calls all the time to see how he was improving. And if after a week he hadn't got better, but those inflammatory markers, and particularly the white cell count, was getting better, with my infectious diseases colleagues, I probably would have given him systemic steroid because, as you can see, it's quite an aggressive inflammation. You don't want to sit on it for too long. But alhamdulillah, we gave him doxycycline, and, within a week, almost all the inflammatory signs had resolved. So clearly, we had gone on the right pathway, but it was just, but we've not actually got any positive serology except for a good response to empirical treatment.
Thank you very much. Okay, I think you have any question, Madav? Sorry, Brasan. Sorry.
So I am, Dr. Fahad, excellent. The way you manage the case. I think one point to draw here is, if you have a patient with a granulomatous bilateral uveitis, I think the most important thing is to rule out the infectious cause. So that's, unless proved otherwise, I think infectious cause is the way to go ahead. So thank you very much for this excellent case.
Thank you very much. Thanks a lot, Fahad. Please stay safe and drive slowly and reach home and inform Dr. Majdi about that.
You can keep driving now, Fahad. Thank you so much.
Yeah, you can keep driving. He allow you now.
جزاك الله خير. بارك الله فيكم. And lovely to see you all.
Thank you. Thank you, Fahad. Thanks a lot.
Thank you.
So now we will have the next presentation by dear colleagues, Dr. Imad Msallam. Dr. Imad, you are here. Dr. Imad? Yes.
Yeah.
Okay. Start share screen.
How are you, everybody? I'm start sharing. I have different topic today. It's sharing.
Yes, Ahmad, you can go ahead, please.
My topic today is rupture globe. I will share for you a case who was admitted through our emergency department with rupture group right eye. The patient, age 13 years old, girl. Visual acuity, right eye it's PL, left eye it's 6.6 with -6. Diagnosed rupture group right eye. This is the picture of the rupture. Little history about this case. This girl was playing with her sister at home, and she fell down and he hit her face into the angle of the table while she wearing the glasses. CT scan showing soft eye and collapsed eye, foreign body, no foreign body there. And as you see, the big wound in the sclera till the equator, the lens is involving and the iris also involving. I will show you the surgery. We are starting preparing the wound to close it. We're putting 8-0 stitches. And as you see, we start to close the wound to perform the eye for following steps. It was a little difficult. And we spent more than 3 hours in this surgery, but I want to show you some steps. I chose for you some steps during this surgery. As you see, we finish with the sclera. After that, we are going now to deal with, as you see, the lens traumatic cataract, and as you see, it's half of the lens it's injured. We use the retractor to remove to aspirate the soft material of lens using vitreotome, keeping the capsule for next implantation. Now we are going for posterior segment. Just we don't know which the picture is there. We evacuate vitrectomy, and as you see, vitreous hemorrhage. We remove the vitreous and the hemorrhage, and as you see now, the big tear in the retina. We repaired this tear with laser coagulation using Takehome. We lift the Takehome, and as you see, we prepared this wound with the tear with the laser coagulation. It was big tear, and we left this patient with Takehome for 2 weeks. And next step, we are going now to try to implant the lens in the bag. As you see, we are using here 4 haptics lens for more stabilization in the bag. As you know, we have a rupture, big rupture, but alhamdulillah, it's going well. And here involved in this injury, the eyelids, lower and upper lids. We try to put stitch in the lids because this is the gear and we need just for cosmetic in the future. We finish with the lower lid. We are going for upper lid, eyelid, and we finish with the surgery. After 2 weeks, the patient came to remove the decline, and after 2 weeks for follow-up, as you see, the lens in the place, retina in the place, and the best visual acuity, it was 0.5. But unfortunately, we have big defect with the iris. Maybe in the future, we have chance to send her for specialized center to prepare the iris. Thank you so much. This is my presentation today.
Thank you, Doctor.
Take care about your children, and it was very hard, especially when I'm driving to hospital. They told me 13 years old, and I have exactly 13 years old girl, and it was very, very difficult. Please take care about your children because it's very bad situation. Thank you so much for today.
Thank you very much, Ahmad. It's an excellent management. Thank you. You have done, I think, more than 5 surgery in the same sessions, which is a good that you are doing cataract, you have doing a retina repair, you have doing eyelids. Oh, it's a great and also a very big, penetrating eye injuries going from the limber to the back. So it's very, very good management. If there is any comments or question to Dr. Ayman.
Can I comment?
Yes, Doctor.
I think the patient was lucky to be dealt with an experienced VR surgeon. So you've done her a good job. But,
thank you so much.
I'm in fact a bit hesitant to do all these surgeries at one stage in cases of trauma. I like myself, this is my approach. I like to repair the primary rupture first, and then I will wait to evaluate the patient more in the coming few days or even the coming first 1 or 2 weeks. You know, cases of trauma is usually, you cannot predict what to find. Sometimes if you go, you might find the bleeding, that it's not clearing. Sometimes we look at the lens, it look traumatized, and then in the post-op period, it starts to clear. So I'm not criticizing what you've done, no, at all. I think you've done a great job. But I think in cases of trauma, this is what I do. I take it one step at a time. The first important thing is to close the globe and then evaluate the patient. But above all, you've done a great job.
I totally agree with you. But this case, unfortunately, you know, with the emergency, first time they can come free treatment, and next treatment it will be difficult to cover all the expenses for this case. And why I'm trying to spend that 3 hours just for this case to help her as we can. You know, that she's girl and she's young, and
you've done a great job.
Yeah, we are trying to. When I'm driving to the hospital, I told my team. I called him. I told him we will do, even it will take 7 hours. We will stay in the hospital 7 hours just to save this eye, because you know the same. I'm repeating again. I have child 13 years old, and I'm just we tried. I know it's difficult. We can wait, but unfortunately with the payment we have some questions and we need to finish at the same time. But finally we got the result, and we saved the eye, and we save
Thank you, Dr. Ayman. It's an excellent.
Thank you.
I think it have a different approach, but what you have done is a great, very nice and excellent.
Thank you so much. Thank you so much.
Is there any other comments, fast comment, or we can go to the next presentation, please? We are already behind the times.
Excuse me, doctor.
Dr. Muhammad, yes, can we, very fast, please.
Yeah, excuse me. As the patient is young with this penetrating eye injury and this surgery, why do you think to use something to prevent PVR, as the risk is there, like using intravitreal methotrexate, or anybody who has any experience?
Okay, is this a general question actually? So Dr. Ayman, if you have any comment about this one, or Dr. Brasan, yeah, Dr. Muhammad is okay. Dr. Ayman, go ahead.
This is a legitimate question, because in young patients with trauma, usually I always tell my patients that probably you will need more than one surgery, and most of the patients, they will need more than one surgery. And in cases of involvement of the posterior part of the eye, posterior segment, usually PVR is inevitable in such cases. Using methotrexate in such a case, trauma as prophylaxis, well, it has been mentioned, but I don't think it has a very strong role in such cases. In these cases, you have to follow up the patient and tackle the problem as it arises, rather than using the
anticipating and give.
The other thing, you have to use profuse post-op steroid. Topical steroid will be helpful. This is the only thing that I will use is the subconjunctival injections and the topical steroids.
Thank you very much. I think
one last comment. Why the use of perfluorocarbon and not maybe? I mean, one of the things in this PVR case is, Dr. Mohammed, silicone oil. I'm not a great advocate of silicone oil, but maybe in this case, silicone oil would have been okay and would reduce probably PVR. And then I think the tear was superior, correct?
Yeah.
So why?
But Hassan, I think here there is a cataract and already posterior capsule not intact. So, and he managed without using the silicone, I think. I don't know.
We think about the silicone, but we are afraid about the silicone to coming to anterior chamber to make some question with glaucoma. But we evaluate the patient daily, and we are ready to take the patient anytime for in case something had happened or like that. But we went during our evaluation, first day, second day after the surgery, it was without any problem, and we think to keep the
Great job.
Thank you so much.
Hassan, let me just a little small comment. I'm not a fan of silicone oil, but in children in particular, I'm very, very, very hesitant to use silicone oil. Silicone oil in children is usually is not a joke, and whenever you can avoid it or even just not to use it, would be very much in favor of the end result of the surgery.
Okay, why not?
If we have a
I'll tell you, patients, young patients with silicone oil, it's very difficult to measure the intraocular pressure for them first. And it's a common complication of silicone oil in children to have raised pressure. I've seen a lot of cases of young patients losing their vision. They have successful retinal surgery, but they end up with very poor vision due to the secondary glaucoma that they develop due to silicone oil. So I'm really very hesitant to use it.
Okay, let us say if we need, then we can use. But if we don't need that, it will be.
I didn't say not to use it. I said avoid it as much as.
Avoid as much as you can.
What about gas? What about gas? Why
gas is a much better option.
Yeah, but so I'm asking why the PFO? Why another surgery? I mean,
yeah, this is a legitimate question.
Yes.
Gas.
I mean, this is a superior tear. I mean, this is not an inferior tear. So my question is, I'm just want to find the reason for that.
Well, I'll tell you something. Using a perfluorocarbon in some cases for 1 week or 10 days, it has been reported.
I mean, I've done it. I've done it for inferior pathology,
yeah,
but
yeah,
not
we can use it. I cannot answer the question. I think Ahmad is in a much better position, but sometimes yes, we can use perfluorocarbon for a week if you have if you want to just to keep the retina attached in certain cases. But I didn't know what was the condition of the retina in that patient.
Yeah.
Thank you very much. Thank you very much.
Thank you.
Please.
Thank you.
Okay. Thank you very much, because we are already on a time, not on a time. I think we are
beyond the time.
Yeah, beyond the time. As usual, we don't know what to do. Okay, now we can have the second the presentation by my dear friends, Dr. Tariq Siddiqui, and he's going to present one case. Dr. Tariq. Dr. Tariq,
yes.
are you there?
Yes, Dr. Muhammad. Yes. Give me one second, please. I'll find my presentation here.
So please, everyone, to open the presentation and keep ready. Especially when the previous speaker already.
Screen. So start broadcasting.
I tell you, don't use.
What's going on?
Yeah, Dr. Ayman, Majdi, you are mute. That's why we are not hearing you. I know your comments.
I muted myself because I speak too much.
Okay. Can everyone please mute himself except the speaker, please? Okay.
Can you see me now, Dr. Muhammad? Can you see my sharing screen? Hello?
Yes, we can see you. We can see you.
Can you see? Can I start? Okay. Okay.
Open the presentation, please.
I don't know what's going on.
No, open the presentation.
I'm trying to
the PowerPoint, so it will show up.
Yeah. Can you see me now?
We can see the screen, but we don't see the presentation. Open the PowerPoint, please. Yes. Now we can see it.
It's open now.
Now it's cool. It's okay.
Okay. Thank you very much, guys. Thank you, Dr. Muhammad Amri, for inviting me for this presentation. It's a quick case here. It was a lady, or 76 years old lady, who has been taking hydroxychloroquine for more than 10 years for her rheumatoid arthritis. And on her arrival to the clinic, her vision was 612 in the right and 618 in the left. And unfortunately, she told me she never been sent for retina screening. As you can see, guys, here in the color fundus photo, you can see there's a retinal pigment epithelium changed around the fovea with the sparing of the foveal tissue in both right and left. And that's why she has some good vision left, 612 in the right and 618 in the left. The bottom pictures shows the fluorescein angiography with the hyperfluorescent corresponding to the depigmentation of the retinal pigment epithelium. Dramatic photo here of hair autofluorescence. You can see two rings in both eyes. The inner ring corresponds to hyperautofluorescence surrounding the fovea, and that's corresponds to the RPE loss. There's another area. Sorry, go back. Yeah, here, if you can see outer ring, hyperautofluorescence corresponded to retinal pigment epithelium stress. Heidelberg OCT dramatic image as well, showing a disruption, or shows a disruption of the EZ layer. And if you focus as well, you can see discontinuation of the external limiting membrane, both right and left eyes. And hair 10-2 visual field shows paracentral scotoma with a reduced foveal sensitivity in both eyes. So hydroxychloroquine is a safe and cost-effective medication, as we know, for rheumatology and for some other dermatology diseases. The mechanism of the damage to the retinal pigment epithelium through it binds to the melanin, is cause damage to the retinal pigment epithelium, and lipofuscin will migrate to the outer retina and finally will cause photoreceptor loss. The cumulative dosage is the critical risk factor and has a more important consideration than all daily doses. And as we all know, toxicity is rare if the dosing is less than 6.5 milligram per kilogram per day, or not exceeding 400 milligram for more than 5 years. So we all know that the disorder is really rare in the first 5 years of treatment. And there was some studies in the States shows that the prevalence of this toxicity for a patient who takes hydroxychloroquine more than 5 years is 7.5, and it's 20% in patients if they take it for more than 20 years. And we have to remember that in advanced cases, it can cause even loss of peripheral vision, and which is called extramacular toxicity. So take-home message from this case: screening is important in these cases, as because once retinopathy causes noticeable loss of vision, the damage to the retina is permanent. It is possible to detect early signs of hydroxychloroquine retinopathy before it causes symptoms. That's why we have to do the screening. And early detection of retinopathy reduces the amount of vision loss detected at the time of the diagnosis. And this allowed the patient and the doctor to find an alternative medication and stop the hydroxychloroquine. Having said that, occasionally patients' vision will continue to worsen. And this is because hydroxychloroquine half-time is quite long. And in some cases, hydroxychloroquine has been detected in bloods and urine of patients 5 years after cessation. We have to remember that other risk factors like obesity, kidney or liver diseases, or old age can really exaggerate the toxicity in these patients. Since the studies in the States came up with a prevalence of 7.5% for patients taking the drug for more than 5 years, there was new guidelines from the Royal College of Ophthalmology in London, who has insisted that we have to use some ancillary tests beside our clinical examination by slit lamp, which is OCT, Humphrey 10:2 visual field, color fundus photo, autofluorescence, and multifocal ERG. So in brief, if you want to screen the patients, you have to do it within 6 times from starting the medication. So it's enough to start with a fundus photo, color 1, with OCT, spectral domain OCT. If the test is normal, you can repeat it in 5 years' time. But if you have any other risk factor, say like obesity, you need to do it every year. In the other side, if you have any abnormal, like if your OCT is abnormal, you can do 10:2 visual field. If these 3 tests are abnormal, you need to discuss the drug cessation with the patient and his rheumatologist. This is, sorry for this busy, hello? Hello?
Go ahead, we are hearing you. We can hear you. Okay, carry on.
You can hear me, sorry, pardon me. So this is a bit, sorry, this is a busy slide here, but this is for patient who has started already and been selected for screening. So in summary, if you have in the left-hand side here, if you have a normal OCT and autofluorescence, you need to do Humphrey visual field. If the Humphrey visual field is normal, you need to consider multifocal ERG. And this side, if you have 3 of them, the Humphrey visual field, the autofluorescence, and OCT are all abnormal, then you have definite toxicity. And you can really grade the severity to mild, moderate, severe if you're interested, guys. I'm all done. Thank you very much.
Thank you very much, Dr. Tariq. Very nice.
Can I
and
make
also
a
very
comment?
short, very, I will, yes, Dr. Majdi.
Can you keep sharing the screen and show us the autofluorescence picture? It's a very nice one.
Yes, I will,
Can you show us the autofluorescence? It's a very good one, by the way.
Go back here. Sorry.
I want to ask.
Quite dramatic, isn't it?
It is. No, but you said 2 rings. Actually, you have 3 rings.
Yes.
You have a central ring of hyperautofluorescence, surrounding by another ring of hypoautofluorescence, and then a 3rd ring, which is in the left eye of hyperautofluorescence.
Yes.
We all know that in fundus autofluorescence, in the fovea, you have to have normally hypoautofluorescence. Once you have hyperautofluorescence, so it means that the RPE in the fovea is already stressed because of the binding to melanin, which prevent the hyperautofluorescence. So normally the fovea is supposed to be black. So the fovea is white here, which means that the foveal cells is already stressed because of the melanin destruction and the RPE changes. And then
probably
the black area surrounding, it means completely dead RPE. And then the surrounding area stressed RPE. So this is a very late advanced stage. I've never seen a case like this. I
Exactly.
always see, because the patient never wait until both eyes is destroyed like this. These eyes are not recoverable. It will not regain vision again because it's completely foveal destruction, melanin, photoreceptor, external limiting membrane. So I've never seen a patient in this advanced. This is why I wanted to make comment. It's a very nice picture. We don't see it even in the literature. It's not there. And having a picture, bilateral, symmetrical, affection, because most of the patient comes when one eye starts to be affected. Once the both eyes are affected, the patient comes very rapidly. But this patient waited for a very, very long time. This
beautiful description, Dr. Majdi. Dr. Musa, that was an amazing description. Thank you.
Thank you. Second thing, you gave us a very nice illustration at the end. If the ERG is abnormal, if the fluorescein is abnormal, if the OCT is abnormal, what is the abnormal thing we are looking for? This is very important. You are talking about fluorescein. Fluorescein at the beginning, nothing to see. In early stages, there is nothing to see because mottling is very tiny, will never be detected. This is a very advanced case which you showed us, we call bullseye maculopathy. Bullseye maculopathy, it's common in dystrophies, and this is in the differential diagnosis, bilateral symmetrical. But this is advanced. In the early stage, fluorescein has no rule. Don't do fluorescein angiography.
Yeah, exactly.
And field of vision. But the trick here for the audience, which will show the presentation first? Is it field of vision or OCT? If you have the choice to do one of them, probably the OCT will be much more peculiar because you look in the perifoveal area and the saucer shape deformity, you see it. You find photoreceptor damage in the parafoveal area, not in the fovea. The fovea is intact. That's why come the patient with paracentral scotoma and the vision is 6/6. But they are still complaining of blurring of vision, or you mean that the sensitivity is low. So OCT is very high in detecting very early changes. Field of changes sometimes comes with the OCT. But if you have the chance to do only one, do high definition, vertical and horizontal line scan in the fovea, you will find the very, very early changes. But I like your case because it's a very advanced, it shows everything, fluorescein, OCT, and fundus autofluorescence, which is not the typical, it's beyond the typical. We never see this advanced case. So do OCT first in the screening, it's easy, non-invasive. You can, it's also objective, not subjective. Field is subjective, so it depends on the patient and the fallacies are high. But objective test is very important, like OCT. If you find any tiny changes, you will start to stop or change the treatment for the patient. So my advice is OCT first. If the patient come advanced, you can do everything. OCT and fundus autofluorescence will do. So if you have a machine with OCT and fundus autofluorescence, that's it. That will do, and you will discover early cases. Thank you so much. It's a very good case.
Exactly.
I just like to say something, Dr. Mohammed, just emphasizing.
Yeah, we need very fast because we are already.
Yes, be very quick, because we see lots many cases of toxicity to the hydroxychloroquine, and I'll just emphasize on Dr. Majdi's point that we should, once the patient reaches bullseye maculopathy, that's very advanced, that's very late, and it's not reversible. So clinically, you should look for early RPE mottling, you should for blunted foveal reflex, and then in the OCT, because there's a deposition at the RP level, so you should look for IS, OS, junction abnormalities, and autofluorescence that sometimes we don't use. In these cases, screening is very important. We should look for early signs of hyper-autofluorescence that later on will become hypo-autofluorescence. So I think stepwise approach, clinical, autofluorescence, OCT combined in a screening package is very important.
Yes,
just a quick comment, Dr. Amri.
That's what goes with the Royal College of Ophthalmology recommendations or guidelines here, guys. Yeah, as you can see in the present slide here.
Yes.
Yeah.
Okay. Is there
anyone? Just make a quick comment. So in the National Health Service in the United Kingdom, obviously we offer hydroxychloroquine screening, and just to support what Dr. Musa said, in my opinion, the tests that are most helpful is the autofluorescence, then OCT. Visual field can be variable and it is subjective. So often when there's a visual field abnormality but the other tests are normal, then we'll often use the multifocal ERG to be the deciding factor. The only thing I would want to say is that in the NHS, we are mandated to screen every patient, but a lot of the doctors are working in the private sector. And what I would encourage you all to do is to reach out to your dermatology colleagues and your rheumatology colleagues and encourage them, any patient that they start on hydroxychloroquine, that you set up a local screening program in your own hospital, that you see these patients annually. Because like all the doctors on the panel have said, we don't want the patients to get to this advanced stage of disease where now stopping the medication isn't going to recover vision, and now this patient has lost use of vision. In fact, I have a worse case where the patient had completely extinguished electroretinogram because the rheumatologist ignored her visual symptoms and she was referred too late. So in the UK, we've been running the hydroxychloroquine screening program as described in this presentation for the last 2 years, and we've been able to stop the treatment at a fairly early stage where we're seeing objective changes on OCT, on autofluorescence, but with asymptomatic patients. So we're able to stop the treatment before that patient loses vision, before those changes are irreversible. So all I can do is implore those doctors in private healthcare systems that they just do the right thing, the ethical thing for their patient, and set up a screening program with their rheumatology, dermatology colleagues, because you will make a big difference for these patients and pick up that 1% who is going to be harmed by hydroxychloroquine, and then you can stop treatment before irreversible changes set in.
Thank you, Fahad.
Yeah,
Thank you very much.
Fahad, can I say something, Fahad? If you go back to the slide.
Can you please stop sharing, because we want to make the other doctors.
If this comment while Fahad is driving, how about if he was not driving? How would have he been commenting? I mean, this is a very good comment while you guys driving. He's concentrating in both things in the same time. I like this guy. I like him.
But he is driving in the opposite. He's going back home. That's why he can't talk now.
I mean, commenting and
Can
driving.
I say something? Last thing, Dr. Muhammad.
Yes,
just
please,
I mean, back to Fahad here. I mean,
Dr. Hassan, can you start sharing your screen? Yeah, go ahead, Dr. Tariq. Yeah.
Yes. Okay. I mean, just back to Fahad here. I mean, in 2018, the Royal College of Ophthalmology has allocated a couple of consultants to look at these guidelines, because if you look back to their previous guidelines, 2009, there was no available evidence that says the hydroxychloroquine retinopathy was common. It was rare, so they didn't recommend it. But after the evidence from the American Academy of Ophthalmology in 2016, and couple of studies came up with a prevalence 7.5 over 5 years and 20% over 20 years, they decided to have a look again. So
that's right. I mean, it's interesting. There are going to be some papers coming out from the UK. So keep an eye out in the British Journal of Ophthalmology, in American Academy. But you're going to find that in the UK, the real-world prevalence hasn't been as high as the American. But still, we've identified a good number of cases.
Dr. Muhammad, can you mute everyone, please? Everyone mute himself.
Okay, no problem.
No, go ahead, Fahad. Go ahead, Fahad.
Oh, sorry. Yeah, so in the UK, our experience has not been like the US. We don't think the prevalence is as high, but I still think I'm glad that we do it. And watch the space. You may find that the guidance will change. You might find the visual field will be dropped, and it will just be OCT and autofluorescence, and possibly maybe not seeing them every year, but every 2 years. But honestly, in the private sector, if you can see these patients annually, if you can do all the tests, I think you should. And I encourage all the doctors in the audience to set up the screening service. Not only will you bring in increased revenue to your department, but wallahi, you're doing a good thing for these patients, because hydroxychloroquine is an excellent drug. We don't want to discourage our dermatology colleagues, our rheumatology colleagues from using it, but we have to screen these patients to pick up the changes at an early stage.
It can be done as a virtual clinic, Fahad, as well.
That's right, yeah. So in the UK, I run it as a virtual clinic, and in fact, I don't even look at the images. It's done by a trained nurse practitioner or optometrist practitioner who works with me, and then as soon as they identify the changes, they discuss the case with me. So in fact, even I'm not looking at all the cases.
Thank you very much, Fahad. Thank you, Tariq. Yeah, thanks a lot.
Thank you much.
Yeah, can we go Dr. Hassan? Yeah.
Assalamu alaikum.
Hassan, sorry for delaying you. Can everyone
Muhammad.
mute himself, please? Everyone, Dr. Muhammad Hashki, please mute yourself. And or I ask the management here to mute everyone, please. Go ahead, except the speakers. Yeah.
Thank you, Dr. Muhammad, for the invitation, and thank you for all the attendees to be late with us. I'll speak today about macular hole reopening post-retinal detachment repair. This young man, bilateral pseudophakic, he attended us sudden loss of vision, multiple tears, and suspected macular hole. You can see through the OCT there is full cleavage here. Patient underwent surgery and ILM peeling, and second day post-op, you can see that there is edema in the OCT, and 3 months later, the patient have a good foveal reflex. After silicone oil removal, the patient developed macular cystic change and then macular hole reopening, and as there is kind of small bubble of air in the eye after 1 week, I advised him for face down position, and he came back by increasing the cystic spaces, and you can see here there is small oil droplets under the retina. So even you can see the whitish area. I give him Diamox and non-steroidal anti-inflammatory drops, and advise him for supine position against to the other side. And then he come back 1 week later. There is no silicone eye under the retina. There is no whitish area here. But the choice is here for me. What should I treat the patient? Should I go for observe the patient? I've discussed this case with my colleagues in the hospital, around the hospital, because this patient become upset that why this is happening for him. So observation, it could be a solution, because there is few cases of reported that spontaneous closure. Surgery, which was the most common treatment. Steroid injection was, we should do it because there is no so much reports about that we can give him. But after we discuss it, that we decide to give him subtenon injection, and the patient after 2 weeks there is the reduce in the cystic change, and after 1 month the patient, the vision is come back for 0.1. And you can see the reflexes, the foveal reflex become better, not as before, but it's become here 1 year after that. The patient under Nevinac drops, and you can see the reflex here, and the vision become back for 0.2. Macular hole reopening, because of the patient, we should especially here we have case with retinal detachment. We should differentiate between patient with myopia or without myopia, because in myopia you have viscerostaphyloma, scleral elongation, atrophy of the retina and the choroid, and the macular hole is the cause of the retinal detachment. But in our case, the classic retinal detachment, there is peripheral tear, and there is atrophic maybe foveal layers or traction in the fovea, so which cause macular hole. And we generally will deal in these cases as a macular hole, because in our case, you can see the retinal detachment didn't come back, but the macular hole come back. So the reopening macular hole rate post ILM peeling, if you did the ILM, it's around 2%. But if you without ILM peeling, it will be around 7%. The pathogenesis of this idiopathic is the most common, because there is incidence of reopening reports even after 10 years of the success surgery of macular hole. Inflammation, it could be as in our case, which we through the treatment, attractional because of remnant of ILM or a peripheral membrane. And this is here you can see that through the literature is that most of here this is large size of cases, around 900 patients. They found that the patient who underwent ILM peeling has better closure and success rate. And again, the aberrant membrane existence, it's the same as if you didn't remove the ILM. It will increase because of the gingival traction, it will increase the reopening rate of the macular hole. The stored macular edema, this is which in our case, which we face it maybe. And here is this study around 200 cases. They evaluate the cataract surgery post macular hole surgery. And they divided the patient for 4 groups. And some patient who did phaco before the macular hole surgery, or with the macular hole surgery, or post macular surgery. And they found that the group in the patient who did the phaco after the macular hole surgery, they have a higher sevenfold more risk to get reopening. And they explain it by the cystoid macular edema. In spite of, in this study, the recurrence was treated by surgery, not by any steroid or any even conservative treatment. About how to avoid this complication, especially there is a few reports or these cases which traditional retinal detachment macular hole and few cases, but which studied good is the macular hole retinal detachment in the myopia. And it's already here is the systemic review with meta-analysis. They found that inverted ILM flap has a better success rate and closure than just ILM peeling in the myopic macular hole retinal detachment. So, and this is the flap. It's provoke this ILM flap. It's work as a scaffold for gliosis and which close the macula. And here is there is two cases in my from my cases around 3 years back. It's macular hole. I did for him ILM peeling, flap, and here the patient even post 3 years you can see good reflex. And here the second case of giant tear with macular hole, and he has a glaucoma. And you can see here I put the ILM here with some gliosis, maybe it was more, but still even after oil removal, the patient even since more than 3 years, it's stable. Resurgery for these cases in the macular hole reopening, we should differentiate between the failed macular hole or the reopening macular hole, because the closure rate is high in both if we decide the surgery. But the vision gain in the group which the failed macular hole is better, and 50% of these patients, they have improvement more than 2 lines. But about the reopening, the improving in the vision is not documented well. And this is systemic review with meta-analysis for these cases. So if we maybe reopening, if the patient has a reopening of macular hole, maybe the vision will not come back as if the patient has a failed macular hole. The conclusion, reopening of macular hole with cystoid macular edema component, conservative treatment could be or posterior subtenon steroid injection. Surgery in macular hole reopening has a high closure rate. Inverted ILM flap techniques reduce the macular hole reopening and rheumatogenic retinal attachment with macular hole. Thank you. Thank you for listening.
Thank you very much, Dr. Hassan. Also on time, excellent. And this is very interesting case. I think all surgeons here, they will comment. I will give only 1 minute, 1 minute for everyone, not more. Dr. Ayman?
Can I ask Dr. Hassan?
Yeah.
Why did you wait? Why you did not think of doing another surgery? As in the previous surgery, I'm sure that peeling with the ILM was not that possible, and even if it was done, it would have been a small peeling. Why not to go ahead, do a proper peeling, and then refill the eye with gas? This would give you probably a more comfortable result. Why did you wait, Dr. Hassan?
Yes, because Dr. Ayman, I did surgery for one patient with macular hole. I have experience maybe in this to do flap. The patient didn't improve the vision, and this patient was critical. And for me, the shape of the macula, the shape of the fovea, and generally when I remove the ILM in the retinal detachment, I remove all the macula. I don't keep it, and the patient hasn't any traction. If you saw, it's like mountain. And I feel there is a position in between this edge of fovea and there is cystic change. And the cystic change which make me, even if I go for the surgery, I should maybe even make the drainage through this fovea. So I said for me, let me try this treatment for him, the steroid. If he didn't respond, then I will decide for him the surgery, because the vision for the patient, even in the best scenario, it was 0.2 after the first surgery. So if I go for him, I do for him ILM flap or any just maybe he will not improve. So about that, maybe even I discussed with many of my colleagues, I found that let me try for him the steroid, as there is some report about that, even spontaneous closure, and which already worked here. The patient got back and the patient was happy. And I feel this should be, if you have case like this, you remove the ILM and you have a small gap in the macular hole, and with cystic change, maybe if you use the steroid, subtenon steroid, maybe the patient will improve and you will avoid the surgery for the patient.
Yeah,
thank you very much.
It's the spontaneous closure in the reopening of the macular hole is not that common, you know. I think both of you were lucky that it's closed. I think you have a better chance by doing surgery, even if you've done a very proper ILM peeling. Just fill the eye with a long-acting gas is sometimes enough to close the hole.
May I have a comment? Dr. Hassan,
Yeah.
excellent case. But I think we need to differentiate two different conditions. So most of your articles which you mentioned, there's a distinction between idiopathic macular holes and macular holes with a retinal detachment. So if you're talking about reopening of idiopathic macular holes, those are totally different from macular holes which are associated with a retinal detachment. So I think one way to differentiate is it's important to differentiate because the pathologies are totally different. And the second thing is when you did the surgery, was there a primary hole in the patient besides the macular hole? Was there something else causing a retinal detachment, or was it the macular hole which is causing a detachment?
The patient has multiple tears in the periphery. The macular hole, just clinically, you can see there is red reflex.
Was there actually a macular hole? Because I think you depended more on the OCT. The OCT didn't show a classic macular hole. There's some sort of a thinning or something.
If you maybe I don't bring the fovea, the OCT after the surgery, you can see there is full thickness cleavage from all the retina, which already was in the pre-op. So for me, I know that. Thank you to say that about the macular hole. In the traditional retinal detachment, like in our case, the problem is not the fovea. The problem is the periphery. And here we treat the periphery, but the patient come back by the macular hole, which it looked like the macular hole surgery. I explained that we should differentiate between myopic and traditional retinal detachment. A traditional retinal detachment, when you treat the retinal detachment, will not come back. The problem with you just the macular hole, because already you remove the ILM and now you have just open macula. The patient isn't, even after the macula maybe become even more than 600, there is no retinal detachment come back. So for me, I depend on the macular hole literatures to explain this, because this patient is a metropic and he has macular hole. There is no retinal detachment now exist. Yeah.
Muhammad Naeem here with us. Okay.
Yes, Dr. Muhammad. Yes, I'm listening.
Okay. If you have any comment, because you are in the panel for us.
Yes, it's a very debatable topic, but I have seen that it's you need to be very individualized approach. You cannot have hard and fast rule whether you'll do it at the same time or do it the next surgery, because I've seen sometimes with myopic RD repairs, they have a high tendency of developing macular hole later on, or trauma cases. So it depends a lot on the pathology. So I think each case should be treated individually.
Also, okay, Hassan, if you have a comment, yes.
Yeah, I just to follow up on your comment, for macular hole surgery, I almost always go for routinely for cataracts extraction, then vitrectomy for macular hole to reduce that risk of macular edema and reopening of the hole.
Okay, Imad, if you have any comment, Dr. Imad.
Yeah, good presentation, but again, it's depends on the case to case is different situation, and you should decide exactly with the case. It's difficult to no rules with that. It's difficult to decide what.
It's case per case, as Dr. Muhammad mentioned.
Yeah.
Dr. Majdi, if you have any comment or question, I have two questions before we move. We finish. Dr. Majdi, if you have any comment, please. Or okay. There is one question to Dr. Ayman. Could you please share any experience of macular hole formation after epiretinal membrane peeling? Very fast, Dr. Ayman, please. You are mute. You are mute, please, Dr. Ayman. You are mute.
Yes. Yeah. There is always a risk when you are peeling an ILM over an edematous macula or a thin fovea to have or to create a hole. There is so many techniques to avoid this. The first one is when you are peeling is to leave the ILM over the foveal area. So it's called the foveal sparing ILM peeling. Whenever you have this risk, you do it, and definitely will decrease the risk of developing a macular hole. Luckily, I haven't faced any macular hole development in my peeling or in case of epiretinal membrane peeling, because I usually I'm really very careful when I'm peeling. I'm do it as I've shown in my videos. I do it very gently. I do it very slowly. Although you cannot guarantee that you will not develop a macular hole. As I told you, whenever there is a high risk, just spare the foveal area.
Thank you, Dr. Ayman. Last question for Dr. Tariq, please. Dr. Tariq, if you are with us, can you unmute yourself? Okay.
Yes.
Mohammed, I have a quick question as well.
Okay. After 5 years, if you have a patient with he's using chloroquine, and after 5 years, how frequent you will do a screening for him?
Yes, so screening starts within 6 months from starting hydroxychloroquine. So if these results are normal, you repeat it in 5 years' time and then annually since. Because the incidence of is higher after 5 years, so you do it annually after 5 years.
Okay, Dr. Fahad, please, yes, if you have a question, last question from Dr. Fahad.
Yeah,
Dr. Fahad.
Just to the VR surgeon. So there was a patient who was listed for left cataract surgery by a colleague. It landed on my list. She had macular hole in the fellow eye, and the preoperative OCT had the posterior hyaloid was still attached. So I warned her of the risk that she may get macular hole formation after cataract surgery. And then unfortunately, although the cataract surgery was uneventful, she did develop macular hole formation that needed vitrectomy. Is there anything I could have done during the cataract operation to reduce that eventuality, or was the important thing that I just counseled the patient that this was a possibility?
I need this, Dr. Majdi. If you have, can you comment? Of course,
yes,
Dr. Fahad.
I don't think you did the best thing, because you cannot anticipate which will develop macular hole, which not, because it sounds like the stage 1 macular hole with a vitreomacular traction. But as long as you are doing the best thing in the surgery, the best thing is to avoid fluctuation also. I mean, keep the anterior chamber formed most of the time, otherwise the fluctuation might induce a macular hole. But you cannot anticipate if there is going to be a hole or not. So the best thing you did is phaco, consulting the patient, and post-operative, if she developed macular hole, as she would have surgery. But I don't think you should have removed the vitreous, do surgery at the beginning, because it's a stage 1, so there is no way to anticipate if she's getting macular hole or not. So the best thing is to consult with the patient. Once she get that, she will believe that you did tell her, and she would do a surgery. This is, I think, my comment.
Thank you very much. We came now to the end of this session. Thanks for all speakers, starting from Dr. Majdi, my dear friend, Dr. Hassan, Dr. Ayman Medanat, Dr. Tariq, Dr. Hassan, Bahrani, my dear friends, also Dr. Imad Musallam, Dr. Brasan, Dr. Fahad Kuhail, Dr. Muhammad Al-Hashki, and Muhammad Naeem. My regards to him and all. Thanks for the participant for being with us till this time, and we'll see you inshallah. Tomorrow is the last day of our.
Thank you.
Thank you so much.
Thank you and good night.
Thank you so much.
Thank you and
Good night, everybody.
Thank you.
Tomorrow,
Good
inshallah.
night.
Thank you, everybody.
Thank you, everyone.
I want to announce that. Thank you very much. We want to announce also that we are also live on Facebook and YouTube, and there is a lot of people that are also following us. Anyone who missed this very interesting sessions, especially by present my dear friend Dr. Majdi Musa, he is all the times, he don't like me. They can follow us and see us on YouTube.
Thank you.
Thank you very much.
Thank you so much. Thank you.
Dr. Ayman, goodbye.
Dr. Muhammad,
Bye-bye.
one thing for
you.
tomorrow.
Yes, Dr. Ayman, please.
Can you hear me?
Thank you.
For tomorrow's lecture, it will be highlight or update on lamellar hole surgery?
Yeah, tomorrow, yeah, we are going to have